Good morning. What I'd like to do today is follow up Susan's talk, and we're actually going to try to put another symposium on in Rome that's going to be a little more elaborate with the sports medicine theme. I think it's an important topic, especially the translation to athletes. Susan's very involved in the post-traumatic model, and it's of great interest to me. Being in Florida, I have an elderly population, and I also have athletic populations. So I've seen the similarity between arthritis in athletes and arthritis in the elderly. And the thing about athletes is you can use them as an accelerated model of arthritis because it happens in a very quick period because of the unique aspects that they put the stress on their joints. Some of the other reasons why this is I think very important and germane topic. Patients are interested in it. We have a lot of weekend warriors, and they want to continue to do their sport. Obviously, professional athletes are highly interested in continuing their sport because of financial and also their personal reasons. That's who they are. But also, I have patients who come into me and they're looking for alternatives. They don't want a total knee replacement, and that's what's being offered to them. So they look for alternatives. I had a patient who has rheumatoid arthritis, and she said to me, well, how does stem cells or regenerative medicine work if I'm on Enbrel, if I'm on a TNF alpha blocker? And that's a very interesting question. So I have a lot of sophisticated patients who do their research, and they actually want intelligent answers, so I'm going to try to present it in such a fashion. And then I get other patients who their orthopedic surgeon tells them there's no science behind this. One orthopedic surgeon told my patient last week that this is voodoo. So I hopefully will present some information that clarifies that. And when we look at some of the articles that are written from sports medicine model, you'll see that one writer last year said, we have a problem with stem cell treatments. And the other is saying that this is cutting-edge treatment. When you understand tissue repair, we're just trying to heal these patients with whatever regenerative application we have. We cannot make a patient bionic. The best repair you can get is 100%, and generally we don't get 100%, but we're not trying to do anything artificial with this patient or doing anything elaborate, except for to try to promote tissue healing. So what's really the difference between sports medicine and osteoarthritis? When we look at athletes, and we see some very famous people, Joe Namath, Brett Favre, Bo Jackson, Peyton Manning. Peyton Manning was famous. He went off to Germany and had stem cells in his neck after he had a neck fusion. Well, what these athletes all want is they want to prolong their career and prevent, ultimately, arthritis and ending their career. Well, Joe Namath was very famous in that he ended up with bilateral total knee replacements. So the difference is really time. And if we can make a difference in time and deter or prolong the interval from them developing arthritis, then we've done our job. But that's exactly what most patients want, is they want quality of life, they want to deter arthritis, and they want to engage in a functional life as possible. So if time is the difference, this particular patient, if you look at his injury just from this model, he's really going to develop arthritis before he ever sees a sports medicine doctor. The trauma that's occurred there is instantaneous arthritis. These are two very famous athletes, Joe Namath and Denny McLain. In 1969, Joe Namath was the biggest name in football. He won the Super Bowl and was MVP. In 1968, Denny McLain was the MVP of the World Series for the Tigers. Joe Namath is very famous. Again, he had both knees replaced. His career was derailed early for constant knee problems because he had numerous surgeries, so he developed arthritis at a very young age. Well, Denny McLain didn't have the same problems during his career, but he developed it later on. He called me this year and said, I'm scheduled for a knee replacement, but I don't really want it. How does this stem cells all work, and what's the science behind it? So I started explaining it to him, and I started discussing some of the scientific basis for what regenerative medicine did. And then I explained to him what we're trying to do is catch patients earlier and earlier so they don't develop Joe Namath knees. And then he responded to me, "You mean Denny McLean knees, don't you?" And I thought that was kind of humorous because obviously they were a year apart and they have egos, as all athletes do. But if you look at them, these are not the same patients, okay? And so this is not cookie cutter medicine, and it's not simple. You have to individualize it for each particular patient. So Denny McLean is now over 300 pounds. His knee is not the same as Joe Namath's knee. And so there are differences in patients. So it is a more complex issue than just saying we're going to put a cell in or we're going to apply a certain strategy to each patient because they're all different. So in the acute stage, when somebody's injured, you get pain and swelling, and depending upon the type of injury, if it's an ACL or an MCL or medial collateral or meniscal injury, you're going to get an associated level of trauma and some immediate cell death. Mary Goldring has said that if you have disruption of the collagen network, then it's irreversible. So if you think about the injury and then you start thinking about what has actually been disrupted, like that weightlifter that you saw earlier, it's pretty clear the trauma that was involved there is going to be irreversible. Therefore, arthritis is inevitable. And the subacute phase is actually within the first few months, and you get a spreading of the cell death or the cell apoptosis actually spreads beyond the original site of injury, so it can be become more advanced. And what I see is a lot of people who think that they're going to get better, and they use the old Rice principle, rest, ice, compression, elevation. They think it'll get better. But in actuality, as Susan pointed out, that there may be this therapeutic window when people need to be treated acutely, and they just don't ever present to a physician because they think it'll get better. The chronic phase is actually just a spectrum of OA where they're going to be on this curve. They have this irreversible injury, and then it's just a matter of time how fast it progresses to the end stage where you're looking at a joint replacement. So we're really just dealing with a spectrum of time, and if our goal is successful, then we're going to deter it or delay it or prolong it so it is less of a problem for the patient. If there's blood in a joint, or a hemarthrosis, there are certain things that happen. It induces a reactive synovitis where the inflammatory cytokines help to propel this. The hemosiderin molecules will actually induce more cell apoptosis. So if you have a very large hemarthrosis, it actually makes medical sense to drain that to get the blood out of the joint because it does damage initially. In cartilage repair, we're actually looking at the balance of whether we have anabolic or catabolic factors. If the cytokines are leading more towards a degradated pathway and it overweighs the anabolic pathway, you end up with degeneration. So our job is to try to see if we can balance this or actually tip it in the anabolic direction where you're actually getting repair. It's more complicated than that because there's repetitive injuries from mechanical factors. These athletes are continuing to beat up their joints, so it isn't just a one insult thing. We're putting them back on the field the next week, and so we have to consider that. There are genetics. Some people have good joints, some people have bad joints. The inflammatory mediators, nitric oxide, prostaglandin E2, all these things can perpetuate the cycle. Even anti-inflammatories may actually propel it by inhibiting some of the necessary feedback loops. There's systemic factors from being overweight in some of our athletes and then just continued trauma. We can monitor some of these effects by analyzing the breakdown products of the degradation cycle and perhaps use that data to guide our treatment. Fat, as I said, can be a very detrimental thing. We have football linemen who are over 300 pounds, and that's in our society now the norm. But if they're bulking up and they're eating everything possible, a lot of them that I found are very inflammatory, and the inflammatory fats secretes not only cytokines, TNF-alpha and interleukin-6, but adipokines that act just like the catabolic cytokines, and this can be a problem not just for our athletes, but for many of our patients as well. As Susan pointed out, the experimental model is quite interesting. I've learned a lot from that. We know from taking the meniscus out of a goat, if we take the entire meniscus out and put cells in, we can get some repair. Rabbits will spontaneously repair to some extent, but goats and sheep and humans do not. So we can use these as models. And if we deliver a certain impact load, as Susan described, we will get arthritis, and there's a therapeutic window where you can prevent that. More elaborate studies that they've done with BMP7 and IGF-1, there's a synergistic effect. So if we know there's a therapeutic window, then perhaps we can make a difference by treating patients early and aggressively. This is an experiment I did on myself. I thought it would be smart to use very large skis and throw myself down a mountain very fast. So what I did was I tore my medial meniscus and my ACL, and this is a picture of my arthroscopy. And at the time, I was awake, and I thought this was very fascinating. And I was watching my friend, who was the orthopedic surgeon, take pieces of my meniscus out. Now that I'm into regenerative medicine, I look at it and I'm slightly appalled, because what he's doing is he's pulling parts of my meniscus out. So if you abide by Dr. Goldring's statement that disruption of the collagen network is irreversible, I think that looks rather irreversible to me. So lo and behold, 17 years later, I've got quite a bit of knee arthritis. So I'm stuck with a decreased medial joint space, and I'm facing eventual total knee replacement, which is not very amenable to me, as I'm a very athletic person, and I don't really want knee replacements. So as some of my patients who are athletes, I opted to pursue cell therapy and see what difference it would make. So first you got to get some cells, which I had a friend harvest some cells, and then I put the cells in my own knee, as any good experimenter would do. And then this is my radiographs 7 months later, and I definitely have improvement in my medial joint. Not all patients will repair cartilage, and I have my own theory because I've seen so many different types of patients. Their patients are not all the same. My experience is young, healthy athletes do extremely well, and they regenerate pretty well. There are some patients who just do not, but I'm quite pleased. I'm asymptomatic, and my goal is to never have a knee replacement. There's all kinds of different mechanical stress, from just overloading the joint. If you're squatting 500 pounds, that's a definite load. It makes sense that you're overtaxing your joint. You can put shear stresses on the pericellular membrane and induce damage to the chondrocyte, or you can just have excessive weight. For every 10 pounds of weight gain, we get 30 to 50 pounds of excess force on the knee, which compounds it, which is quite common in our society. Not only the load effect of being overweight, but the inflammatory fat induces more inflammatory changes inside the joint, so it's a compound problem. This is my first 300 plus pound patient who actually did everything I said. She was 357 pounds, and no one would operate on her knees because she was morbidly obese, so she was too great of a risk to replace her knees. As you can see, she's got no real joint space, and most surgeons would love to replace that knee, but because of her weight, they did not want to do it. So she found me as the last result. This is not my ideal patient, but there really wasn't much other choice for us in this particular situation. So she adhered to my recommendations, fostered a healthy lifestyle, lost weight. This is 1 year post stem cell treatments to her knees. She went from 357 down to 150 pounds, significant weight loss. So she not only decreased the load on her knee, which is beneficial, but there is some reparative effect, more so on this knee than the right, but this is still a bad joint, but she's functional, she's not having any pain. The problem is she's only 51, so we're probably going to have to follow her very closely because her knee will continue to have problems as more time goes by because she's only in her 50s. This is a patient who's a 418-pound football player. He smokes, he drinks, he's diabetic, he has heart disease. He doesn't want to follow any of my recommendations, and he's not going to do well. This is a 300-pound bodybuilder, and just because you have muscle, it's still too much weight on your joints. So what are our options if these patients present to us and they're not surgical candidates? Anti-inflammatories do not deter the long-term arthritic process. Corticosteroids do not. So in our world, we have the ability to do translational medicine now, and we can apply these to the appropriate patients and get some very compelling results. There are biologics, which isn't discussed at great lengths, and scaffolds. We could talk at great length about nutraceuticals. In an experimental model, you can find a laboratory study that will show you can almost stop any process in the lab, but in humans, in proving it clinically, it's very difficult. PRP, the growth factors, may have some anti-inflammatory effect, but it's my personal belief without the addition of cells, especially with aging patients, you're not going to get the same therapeutic effect with osteoarthritis. Cells are much more complicated. There's all these different interactions with the cell surface receptors. Not only the immunomodulatory effect to decrease inflammation, but there are cell matrix effects, and actually CD44 will bind to hyaluronic acid, which is quite interesting because a lot of physicians will use hyaluronic acid as their scaffold. But is the cell matrix receptor supposed to dock to the aggrecan hyaluronic acid, or is it supposed to dock to the hyaluronic acid the physician's injecting into the joint? Nobody's quite been able to point that out to me, but I think at this point we're in such unknown territory that perhaps Mother Nature put that receptor there for a different reason. This is a study from Osiris that did show results, but it wasn't good enough for their desired effect to get it FDA approved. They had about 17% improvement. Their problem was that they took over 50% of the meniscus out. If you take 50% of the meniscus out, you're going to get less than desirable outcome. So the study was flawed, but there were patients who did improve. Quite often I'll get people who say to me that, is this placebo? And I always counter with, you can't make a racehorse run faster if it's lame. And so I think the veterinary model is very good. And also the athletic model. Athletes generally don't respond to placebo, especially when they have financial gain to get better. This particular football player had his knee operated on. It didn't get better. It kept swelling. So he came to me because he was cut. We did some cells on him. The swelling went away, and he got re-signed by another team and has made it to the playoffs last year. This is another professional athlete, a baseball player. He had two knee surgeries by two of the biggest names in sports medicine, continued to have problems, did not get better. He was cut, and I ended up treating him, and he again got re-signed by another team. His agent flew out to see me from Beverly Hills and was very interested in this science. And when I started explaining, arthritis progression to him, he got rather excited and had a twinkle in his eye. And I think the twinkle was that he realized if I could extend his playing career, then that would translate to 10% commission for a few more years. These are some teenage athletes that I've had that they were going to fuse her ankle. And if you fuse a teenager's ankle, especially a female, you're never going to play soccer again. But additionally, you're never going to wear high heels. So even the psychosocial effects from surgical alternatives are quite drastic. So these patients look for alternatives, and offering this, and this particular patient returned to soccer, and she's now being scouted by Division I schools. This particular ballerina couldn't dance, and she had toe pain. And ballerinas that can't dance have to have a big problem because they usually have significant toe problems. So we put some cells in her toe, and she didn't follow up with me. I finally found her 6 months later. She told me that she was back on tour and she felt great, so she didn't feel a need to call me. But I figured that if a ballerina can't dance, then they're really hurting. This particular patient had AVN of his wrist, a scaphoid bone. They wanted to fuse him. He was a high school athlete who got a Division I scholarship, and they were going to fuse his wrist. If he can't row, he loses his scholarship. So he found me, and we put some cells in him, and now he's rowing, and he's in college, and he's very happy. This is a patient with bilateral TFCC tears. He's a physician. He was not getting better, so the recommendation of the surgeon was to fuse one wrist up and one wrist down. He's an athletic physician, so he didn't find that to be a very palatable option for him. So we put cells in both wrists. He still has some pain, but he's lifting weights now, and he's quite happy. This is a 26-year-old who fractured her hip at age 10, so her arthritis developed at age 10. Her hip continued to wear. They want to replace her hip at age 26. Well, if they do, it's going to wear out again, and then she'll end up with a hip fusion at a very young age. So she opted to have cell therapy, and we've now treated her. She's asymptomatic. The problem with her, she's very young, so we're going to have to manage her for some time. But the alternative of having a hip replacement at 26, this provides an option. This is my last patient that I want to talk about. She's 92. She has a pretty narrowed medial joint on this side. This side is not nearly as bad. I certainly have much worse patients than her, despite her age of 92. Her children said to me, "How long is this going to last?" I told her that no one has that data. I've done quite a few 90-year-olds, but so I said to her, given the fact that your mother is going to live to be 120, we may have to repeat it. So they went along with it, and when I got the mother alone and we were doing the procedure, she started talking about her where she grew up in Scotland, and she said her mother lived to be 103. So I said, well, that's an important piece of information. This lady may live quite some time, so now it's a quality of life issue. So if I get this to last to 97 and she's ambulatory and functioning, doesn't go to a nursing home, it's a success. And if we have to repeat it at 101 and she exceeds her mother, well, that's still a good thing. She's ambulating now without any assisted life and is quite happy. Thank you.
Well, thank you very much. In the interest of